Morning, everyone. Thank you, Carly. So it's about time, so we'll begin. So welcome to the first ICU DDR event for the year. Our topic for today is very interesting. Okay, we're gonna talk about something very relevant, which is about substance use and mental health, and most especially preparing the future workforce. So a quick note. So we'll begin with a little bit of housekeeping, an introduction to the speaker, his presentation, followed by question and answer, as well as announcement for future events. Okay. As a reminder, a copy of Dr. Peter's presentation will be sent to everyone who registered for this event, as well as a recording for the video link. If you have any questions during the presentation, kindly use the chat box, and I'm Berna Felipe, and Carly will actually monitor it and ask it later. So remember that we are in a Zoom meeting, so kindly be mindful if you have accidentally unmuted yourself. So I don't see anything from the chat box, no question at the moment. So I'll proceed now with the introduction of our speaker. Our presenter for today is someone near and dear to ICU-DDR's heart. He is a professor in the Department of Mental Health, Law, and Policy at the University of South Florida, where he has served as a faculty member since 1986. I know it doesn't look like it. He looks very young, but he's been teaching for such a long time. And he was also the department chair from 2004 to 2011. In 2015, Dr. Roger Peters served as a Fulbright scholar at the University of Cape Coast in Ghana. And 2 years after, he received a second specialist grant and served as a Fulbright scholar in Universidad Católica in Asunción, Paraguay. Dr. Peters has served as a principal investigator and director for several grant projects, including a NIDA P30 Research Core Center on co-occurring disorders, justice, and multidisciplinary research, and currently serves as a principal investigator on a 5-year NIDA R25 Summer Research Institute grant. He also served as chair and co-auditor of the SAMHSA CSAT Treatment Improvement Protocol. I know that a lot of you are familiar with this. We normally know this as TIP. So it's number 44 on substance abuse treatment for adults in the criminal justice system. And he is also the lead author of the monograph Screening and Assessment of Co-occurring Disorders in the Justice System. Dr. Peters currently serves on the Florida Supreme Court's Task Force for Mental Health and Substance Abuse Issues in the Courts and acts as a consultant to the Bureau of International Narcotics and Law Enforcement Affairs and the Colombo Plan. Colleagues, without further ado, ICU-DDR's Vice President for International Collaborations, Dr. Roger Peters.
Great, and thank you, Verna, for the nice introduction. Thanks to ICU-DDR for hosting this webinar, and it's great to be with all of you today. So welcome. Just a quick question, can you see the screen and the slides?
Yes, sir.
Perfect, we'll move forward then. Great, so the goals of the webinar today, we just have an hour, so it'll go fairly quickly. You have my email address, so if there are additional questions we don't get to today, you're welcome to contact me and we can discuss further. We'll try to leave some time at the end of the session for questions. So today, we're looking at a really important issue, I think, which is how do we address co-occurring disorders, co-occurring mental and substance use disorders for the workforce throughout the world. And it's a really challenging issue, as you know, and it's a population that is very large and that sometimes is not identified as having both sets of disorders, which causes many problems. It's not identified. So we want to look at the importance of co-occurring disorders. Why is that important to gain skills for the workforce? Secondly, we want to look at what are the competency areas that each of us need to be skilled in so that we can work effectively with this population. I think many of us who are working in direct care, direct services, in whatever setting it is, have experienced challenges in working with people who have severe mental illness co-occurring with chronic substance use disorders of one type or another. And then finally today, we'll look at a few adaptations for co-occurring disorders to enhance our existing types of treatment approaches that's used by the behavioral health workforce in both an addiction treatment setting or a mental health setting, perhaps a criminal justice setting, whatever settings that you may work in. So I just want to share with you before we move any further, I will go through some of the slides fairly quickly so that we can focus on the most important points, if that's okay. And again, you'll have a copy after the webinar of all of the slides. So we'll get started. Looking at the importance of co-occurring disorders for the workforce. And I think because of the high rates of co-occurring disorders in mental health treatment settings, substance use treatment settings, and others that we work in, it's important for all of us to be skilled in co-occurring disorders. As we know across the globe, internationally, that people with mental health and substance use problems provide a really large contribution to the global burden of disease and require intensive treatment resources if they're not managed effectively. This is a particular problem among what we might call vulnerable or high-risk populations. And that might include persons who have a history of being victims of violence and experiencing trauma and post-traumatic stress disorder. It includes people in the criminal justice system. It includes people who are homeless and other vulnerable populations as well. And we'll see the rates of co-occurring disorders are very much magnified in these settings. Also, we know that people that have both sets of disorders oftentimes don't have access to treatment, and they may lack insurance. They're likely to lack health insurance or other resources to assist them in engaging in treatment. They typically have poor compliance rates and motivation for treatment. And then if they are engaged in treatment, we see very high rates of dropout and difficulties related to relapse to substance use, also recurrence of the mental health disorders and other behavioral issues that may interfere with treatment. So another key reason, as I mentioned, is that we see very high rates of these disorders in all of our settings that we work with. And so I think it's important for all of us to get skilled and to get training in co-occurring disorders. And this includes the justice system, the mental health system, the substance use system, treatment system, but other systems as well, working with the homeless populations, other type of child dependency systems, other systems like that that have contact with people with co-occurring disorders. So for people receiving treatment in the addiction treatment area, about 50 to 75% have a diagnosable mental disorder. And we'll look at those in just a minute. For people in receiving mental health services, up to half tend to have a substance use disorder. And I would say in some settings, it's even higher than that. So what about in treatment settings? The prevalence of mental disorders in substance use treatment settings. I don't know if you can read this, but this left-hand bar, these are the most commonly seen mental disorders in drug treatment settings. And so we have, for mood disorders like major depression, we have 40% of the addiction treatment population tends to have these type of disorders of depression, other mood disorders, anxiety disorders. The second bar, also very high, post-traumatic stress disorders, from 75% of women in some treatment settings and 50% of men tend to have post-traumatic stress disorders. These figures here, I would say, are a bit low in my experience. And then other types of disorders as well. So very common to see mental health disorders in substance use treatment settings. I'm sorry. Within the justice system, I mentioned this, and I won't spend a lot of time on this slide, but if you look at the left-hand side of this slide, you'll see about 3/4 of people who are in prison or short-term detention who have mental disorders also have a substance use disorder. So if you're working with people in the justice system who have a problem with alcohol, other types of drugs, you can be fairly confident that you're going to see a mental health problems that are co-occurring with the substance use disorder. So where do we find these individuals in the treatment system? If you look at the upper right-hand corner of this diagram, you'll see that for people with the most severe mental disorders and the most severe substance use disorders, they tend to be seen, they end up in very deep end, intensive settings requiring significant resources, such as psychiatric hospitals, prisons, emergency rooms. Now, if we step back and look at that, these are not always the best locations to receive integrated and specialized care for their co-occurring disorders. I've worked in the justice system all of my adult career, for example, and I know that it's very damaging in many cases for people with mental disorders to be placed in detention settings for long periods of time if they're not provided a specialty care and separation from the general inmate population. So this is where we find people if we don't manage them appropriately in either quadrants 2 or 3, the mental health system or the drug treatment system. And I would say, and this is important, I believe, that with appropriate modifications to treatment programs, persons with co-occurring disorders can be treated effectively in either the mental health system or the drug treatment system, or in programs that are specialty care programs that cut across both the drug treatment system and the mental health system. We'll talk a little bit more about that later. So very briefly, let's look at some challenges related to co-occurring disorders. Again, this speaks to why it's important to have specialty training and skills in working with this population. One important point is that this group, this patient population, if not treated effectively, if not managed in the community effectively, they tend to cycle rapidly through the justice system, through the treatment systems, because of high dropout rates and lack of engagement and retention, and other service systems as well. It might be homeless services, it might be economic support, it might be family services and others. People with co-occurring disorders, when they're not taking their medications, when they're not in active treatment, or when they're using drugs or alcohol, they experience significant problems. And so we need to prioritize this population for involvement in treatment so that they don't repeatedly cycle through these systems, and so we can get them appropriate care, given the fact that they're high risk for relapse and for recurrence of the mental health disorder, and for involvement in the criminal justice system. Even small amounts of drugs or alcohol can trigger mental health problems, can trigger the loss of stable housing, and increase contact with law enforcement to the point where they're at risk for arrest and incarceration. And then we'll talk later about this, but this population experiences poor outcomes in traditional mental health programs and traditional substance use programs. And for the workforce, that is an important issue because many of us received our training in only one of the disciplines, and we didn't get proper training in co-occurring disorders. I know in my graduate work in clinical psychology years ago, there was very little content about substance use. There was only one graduate elective course offered in the summertime, And that was the extent of training that you received in substance use. There was none really in my program. So I had what we all learn in our disciplines typically is what we learn out in the field. And so we certainly need a better training to avoid poor outcomes in using traditional approaches in our mental health and substance use treatment system. The other key point that's not on this slide, that's a major challenge, is that effective management of persons with co-occurring disorders requires coordination between the systems that have not always worked well together. And by that, I mean the mental health system, the substance use treatment system and prevention system, and the criminal justice system. Oftentimes, these systems are skeptical of each other. They want to take care of issues within their own setting and not look for expertise outside. And of course, it takes a lot of effort to collaborate and provide coordination between these systems of care. But it's required for this population that move very rapidly between the different systems of care. So that is another major challenge for the workforce. And we'll talk a little bit later about the implications for the kind of skills that you need. But I would say very briefly, in response to the need for coordination, our workforce needs to be expert in navigating the different systems and also understanding the different systems. So one example, I would say in my own training in clinical psychology, I really didn't know much to start out with about the criminal justice system. And only because of my work in federal prisons, in jails across the country, did I actually understand the dynamics and the issues and the challenges in working with people who had mental and substance use disorders in those settings. So some challenges for the workforce because of the importance of collaboration and navigation between the different systems. So we'll move through this very quickly, and you have the slides, but there's so many challenges in working with this population that we need to be aware of. And because of the things that you see on this slide, the services required for this population to effectively manage patients with co-occurring disorders requires a high level of structured services, and again, coordination and collaboration across different systems. So it's not just the high relapse risk for substance use or the high risk for recurrence of mental health disorders, but it's a range of other things that can be very undermining and difficult to engage people in treatment, such as homelessness, family issues, access to transportation. All of these things can undermine the ability to engage a person with co-occurring disorders in evidence-based treatment for those disorders and putting them on a path to effective recovery. We'll talk about stigma later, but we also have significant deficits in education, in employment skills, and family issues, of course, we talked about. Also, many of these services and resources are fairly scarce, particularly in rural areas in our countries. And so this presents an additional challenge to managing this population. And then outcomes related to co-occurring disorders. I won't spend much time on this, but again, you have the slides. We have very high rates of suicide, of hospitalization, people moving very quickly from initial use of alcohol and drugs to dependence on those substances, and poor adherence to medication, particularly if they decide to return to substance use, right? They're going to stop their psychotropic medications for their mental disorders, perhaps, and that, again, leads to a recurrence of the mental health disorders and all kinds of additional problems socially in the criminal justice system and related to treatment. So here's some important points that I'd like to share with you in thinking about this topic, which I think is relevant for all of us. What are the challenges in preparing the future workforce? Well, we talked about some of the important issues about co-occurring disorders, the challenges related to that population. But what about in terms of training for the workforce and getting our workforce skilled and ready to work with this population. So one challenge that I see, and particularly in my role as vice president of ICU DDR and working with universities around the world, we understand that addiction studies programs are relatively few and far between in comparison to mental health training programs. And we've seen recently, we're very encouraged that universities are beginning to develop specialty undergraduate and graduate training programs and certificate programs for people in the area of addiction studies. One remaining issue for those programs is dealing with co-occurring disorders. And so we see in many of the specialty programs for addiction that we're not yet training people in understanding the dynamics, the implications, the specialty treatment adaptations for co-occurring disorders. So one key issue is just not having the training programs for addiction treatment throughout the world. And that's beginning to change. We have existing academic programs, many more of them in the mental health area, as you know, and that's at every level: undergraduate psychology programs, graduate programs at the master's and PhD doctoral level, other types of certificate programs for mental health. But oftentimes, these programs don't fully address co-occurring disorders or substance use disorders, as I mentioned in my own program in clinical psychology. And that has been very slow to change because many of the programs have certain core requirements and they have licensing stipulations that where they have not so much flexibility in adjusting their curriculum. So this is something that has to change to improve our workforce in the mental health area to be equipped to work with the population that has co-occurring disorders. So I would say when we have these deficits in training, whether it's in an addiction studies program or a mental health program at the graduate level or undergraduate level, if you have training in only one disorder, it leads to ineffective practices in many cases. Because, and like all of us, we tend to fall back on the skills that we learned in our primary discipline, whether that's in a certificate program, an undergraduate program, or a graduate program. So we use the skills and apply the skills that we have, but we're not aware of what we don't know about the other discipline, for example, addiction treatment and co-occurring specialty treatment. And so oftentimes we have ineffective practices and bad outcomes as a result of that. The other challenge that I think goes along with that is that when we're treating co-occurring disorders effectively, it requires complex and special skills in our workforce. It requires understanding the interaction of the two disorders, the dynamics of the disorders, assessing both sets of disorders over a longitudinal period and how they interact, for example. And so it's not an easy fix to train people to work with co-occurring disorders. It takes a fair amount of time, supervision, and follow-up training over time. And then finally, the challenge I mentioned earlier is that our workforce needs to be trained in understanding and navigating different systems, whether that's the mental health treatment system, the substance use treatment system, the criminal justice system, other social services such as the child welfare system, the homeless services system, and the list goes on. And so there's skills in case management and understanding advocacy and being able to understand stigma, but also to understand the other different systems that we work with to become expert in collaborating so that we can cut across the different systems of care. So again, because of the high prevalence rates of co-occurring disorders in behavioral health and addiction treatment settings and in justice settings, all staff in the behavioral healthcare workforce and the justice system workforce should receive training in co-occurring disorders. And so let's look at some of the key competency areas related to co-occurring disorders for our workforce. And this could be, again, recognizing that the workforce comes from different types of backgrounds, comes from addiction studies programs, perhaps, leading to an academic degree, programs in mental health at the non-graduate or the graduate level, pre-service training programs such as certificate programs, credentialing programs, or other in-service training that people may receive. For example, people who have an addiction history and have lived experience with addiction and or co-occurring disorders, who now are in the workforce and need additional training related to co-occurring disorders. Here's what I would share with you in terms of the key competency areas for the workforce related to co-occurring disorders. And there are many others as well, but in preparing for the webinar today, I stepped back and looked at what I thought were kind of the core areas that if you were going to develop a training program for the workforce in different settings, these are the ones that you'd want to start with. So first is just the epidemiology of co-occurring disorders. We talked a little bit about that already. How common are these disorders in different settings? How do they affect treatment? How do the disorders evolve and so forth? A second feature of competency areas would be the kind of clinical aspects and the dynamics of co-occurring disorders. How the disorders interact, how they progress over time, some of the challenges in treating and managing this population. We'll go into those in each of these areas. We'll review in a little bit more detail. Screening, assessment, and treatment planning, I consider as the foundation of treatment for any type of disorder, and particularly for co-occurring mental and substance use disorders. And so there are areas that we need to adjust related to screening and assessment and treatment planning for this population. We'll go into that in just a minute. Another really relevant area of a competency in which we need to focus our skills training for our workforce is stigma and stigma reduction. And this is a key area, particularly for co-occurring disorders, because in some cases you have triple or even more stigma than a typical patient in either an addiction program or a mental health program, because there's stigma certainly related to mental disorders, stigma related to having a drug problem, stigma related to being in the criminal justice system, and other types of problems that people may have related to other psychosocial areas of their life. Then the final competency area, of course, is how do you deliver evidence-based treatment? How do you modify substance use treatment and mental health treatment for co-occurring disorders? So these, in just a brief summary, are the areas that I think the workforce needs training in as kind of core competency areas. So we mentioned epidemiology as one of the competence areas. And again, we talked about this already, that we need to understand and be aware of the high rates of these disorders in our populations so that we can screen, identify, and fast track these individuals into specialized treatment services when they're available. We need to know how the disorders have evolved over time. Was it the substance use disorder that began first and then actually elicited mental health disorders over time and continued to add to the likelihood for recurrence of the mental health symptoms when people used drugs or alcohol? How do they interact during the treatment process, for example, and in recovery? What are the risk and protective factors for co-occurring disorders that may not be too dissimilar from those related to persons with a mental disorder or an addictive disorder? What about stigma and stigma reduction? I think that this is a key competency area, not in dealing with patients or clients, in dealing with families or significant others, but also for our own treatment workforce in the behavioral healthcare area, in the criminal justice system, and other service sectors that we work with. And so I think first off, we need to understand stigma among people who have co-occurring disorders and how it affects the recovery process. For example, in terms of motivation for engagement in treatment, not being labeled as someone who has both sets of disorders. I worked in prisons and jails, and I know that people get highly stigmatized who have mental disorders or substance use disorders in those settings from the general population. And because of that, we need to isolate people in treatment who are in criminal justice settings so that they can receive proper care, but also be removed from the stigma that's imposed by others who would be predatory and make light of that. Secondly, I think in terms of competencies for stigma is we need to develop skills for coping with stigma and treatment strategies for our behavioral healthcare workforce to deal with stigma. And so we have evidence-based approaches for stigma reduction in these settings that need to be incorporated into our programs. So again, I think these are key competency areas in terms of understanding and being aware of stigma, how that affects the populations we work with in our treatment settings, but also skills for enhancing our patients' abilities to cope with stigma and to overcome that over time, developing strategies for self-care, for cognitive restructuring, other areas to deal with stigma. Some of the clinical features of co-occurring disorders are really important to understand for our workforce. We won't have time, of course, to go into great detail. This could be the subject of several days of training alone, but just to give you a sense of some of the features that I think are important to understand for our workforce would include cognitive impairment. We'll talk about that in just a second. Reduced motivation, we've mentioned that already. People are not buying into the idea that they need to reduce their substance use. If they have co-occurring disorders, they have many other pressing problems, including their major mental disorder that may be untreated and unchecked. They may be homeless, they may lack financial resources. So treatment may not be front and center as a priority for this population. And then impairment in social functioning and a range of different areas related to interpersonal communication, dealing with conflict, anger management, a range of other types of issues. What about cognitive and behavioral issues related to impairment for this population? And again, I think these features here that need to be part of the training program for our workforce have implications not only for clinical assessment, but also for treatment. And so these would be some of the characteristics I would share with you that I think are unique in some ways for the population with co-occurring disorders. Having a short attention span and difficulty concentrating, remembering and integrating information, particularly verbal encoding and verbal information that's shared during treatment. And just having an unstructured life and disorganization and chaos in much of their daily activities, their daily life, lack of structure, as we mentioned. So, for example, in terms of treatment implications, for the first point, we have to have shorter treatment sessions for this population that may not be able to withstand an hour and a half of a treatment group to gain recovery skills. We need to focus on fewer topics during those treatment sessions so that they can comprehend and integrate that information and so forth. So there are implications not only, and for assessment, we need to check and see which of these features might be damaging and disadvantage people in terms of their functional impairment that might degrade their treatment activities and involvement. Other clinical features, I think, that are important for the workforce in terms of being trained and developing skills. These are, I won't spend a lot of time on these, but again, these are issues that our staff need to be aware of in terms of assessment, but also in terms of clinical interventions and structuring our treatment programs. Many of the addiction treatment programs in the past have focused on confrontation, for example. that you have to admit that you're an addict, that you've reached bottom, that you have to recognize that you have all kinds of problems in your life and need to make changes. And I think people with co-occurring disorders, for example, if you have a paranoid delusional system or other major depression or major anxiety disorder, these individuals aren't going to respond to that type of environment in a meaningful way. And so we have to adapt and change our approaches to become more supportive and educational rather than confrontative related to addiction problems, for example. What about screening and assessment? We know that there are really high prevalence rates, as we mentioned, and so we want to screen and assess for both sets of disorders. We know that people without being detected can relapse very quickly and experience rapid cycling through our systems. Also, when we screen and assess for both sets of disorders, it allows for effective treatment planning, and as I mentioned previously, to link people very quickly into specialized services that they need. Comprehensive assessment approaches for co-occurring disorders have better outcomes in the long term. One thing that in the trainings that I provide related to co-occurring disorders, I always focus on the need for universal screening in each of our settings for these types of issues that you see on the screen. And that's because of the elevated risk for these disorders in our populations and the adverse consequences if you don't identify these disorders. For example, post-traumatic stress disorder or history of violence, oftentimes if that's not identified early on, that someone in treatment will be silent and not want to participate. They're focused on flashbacks and reimagining the violent events that may have occurred in their life. And so that undermines their ability to participate effectively in treatment if it's not identified and dealt with. In addition, there are specific and unique and effective treatment practices to deal with post-traumatic stress disorder that need to be incorporated into our programs to be effectively managing this population. So my recommendation is to provide a screening for each of these sets of disorders across the behavioral health systems that we work in, and also including the other social service systems I mentioned, homelessness, child dependency, the criminal justice system as well. Okay, so I won't go into a lot of detail here, but here's some tips about screening and assessment that are unique, I think, in some ways to co-occurring disorders. Certainly, we need an integrated type of screening and an integrated assessment that incorporates elements of both sets of disorders to look at the functional impairment that's often accompanies people that might keep them from effectively participating in treatment. I mentioned before, if someone has a paranoid delusional system that people are out to get them, and the treatment staff are working with law enforcement or the criminal justice system to put them back in prison, then they can't effectively participate in co-occurring disorders treatment. One thing I would mention that's at the top of this slide that's important is not to exclude people based on a diagnosis of a mental disorder or the fact that they have a substance use disorder or that they've recently been actively currently using substances because programs can be modified to address these disorders and to decrease the rates of substance use in this population. For assessment, I think we need to focus on the fact that these are disorders that have evolved over time. And so we need to look at how they've interacted in the past. For example, have mental disorders and the symptoms of mental disorders only appear when people are using drugs or alcohol. If that's the case, then we can focus on a traditional substance use program without use of necessarily long-term use of psychotropic medication or a specialized co-occurring program for this person, as long as we understand the high risk for recurrence of mental health symptoms and the fact that they perhaps need counseling and they may need medication for their disorders. a lot of challenges in assessing for co-occurring disorders, including the fact that any type of drugs or alcohol can mimic major mental disorders. And so we have to take account of substance-induced disorders as we make a diagnosis and treatment plan for this population. And there are a range of strategies to look at the potential effects of the interaction of substance use and psychiatric symptoms, including waiting until somebody is detoxed from drugs or alcohol to make a more definitive diagnosis of mental health disorders, repeating assessment over time, and looking at a longitudinal history, as I mentioned, of the mental health and substance use symptoms. I'm going to skip this because I think we've touched on every single one of these points. Again, we don't want to exclude people just based on a diagnosis of a mental or substance use disorder. And I would say this is the case in either the addiction treatment system or the mental health treatment system. I mentioned this before, that oftentimes people with post-traumatic stress disorder, a history of violence, and trauma symptoms are often overlooked in screening. We don't provide specialized screening for this, and other diagnoses are sometimes used to explain the symptoms that we see, such as depression, social isolation, antisocial behavior, and we don't effectively identify the post-traumatic stress disorder or other type of trauma symptoms that need specialized care. And this leads to poor outcome and dropout from treatment, as you're well aware. So we need to focus on evidence-based treatment for this population. Again, this could be the subject of several days of training, and I would encourage you to get training in evidence-based treatment. With the key point being that there are now specialized programs that are evidence-based that have demonstrated outcomes with this population that exceed the outcomes in a traditional substance use program or a mental health program. And I won't go into detail on these interventions. I think many of you are aware of cognitive behavioral treatment, relapse prevention, integrated mental health and drug treatment we'll talk about in just a minute, and all of these interventions. One key point is that the most effective programs tend to blend and combine these types of treatment interventions for clients or patients who have co-occurring disorders. Here are some other aspects of treatment that are evidence-based for this population. Again, I won't go into detail, but I can, if you would like more information, I can certainly put you in touch with resources that explain and describe these set of interventions in more detail, including the research for the outcomes. So in finishing up today, as a workforce, what do we need to do to change our approaches to working with people with co-occurring disorders in our own treatment environment? And I would say that having a specialty program in co-occurring disorders throughout the world is relatively rare right now. And so, as we talked about earlier, people can be effectively treated in a drug treatment setting or a mental health treatment setting, as long as we provide adaptations for co-occurring mental and substance use disorders within these settings. So what does the treatment workforce need to know about how to modify these treatment approaches for both sets of disorders? One thing that we know is that traditional mental health services are ineffective for people with co-occurring mental and substance use disorders if there aren't these adaptations provided, because oftentimes the drug use is not addressed, it's not screened for, it's not assessed, there's not drug testing, and it interferes with the ability of patients to take part in mental health treatment. For example, as we mentioned before, that for people that are using alcohol and drugs, oftentimes they'll stop their mental health medication, their psychotropic medication, which then leads to problems with recurrence of the mental health disorder. And then, of course, as talked about earlier, oftentimes mental health treatment just ignores the fact that we need to change substance use and related maladaptive behaviors if we're going to achieve recovery from the mental disorder. And so, again, there's not a focus on both sets of disorders, and there's just a use of mental health treatment techniques without trying to change and reduce substance use and the related problems to that. Similarly, we find that traditional drug treatment programs aren't effective with people who have co-occurring mental and substance use disorders. First off, we don't have accurate diagnoses, and oftentimes our staff are not trained in mental health diagnoses, or we don't have a collaborative partnership with mental health trained staff who can come into our programs and work within our programs to help deal with a mental health diagnosis and assessment and treatment. We know that cognitive impairment for people with mental disorders detracts from understanding and processing information. We talked about that already. We also talked about the confrontational nature of some drug treatment programs that's not well tolerated for persons that have anxiety, depression, paranoid, delusional system, schizophrenia, that need to be adapted to a more supportive and educational approach. And then all of this leads to frustration and dropout for our patients or clients who have co-occurring disorders. And that can be related to the requirements in a drug treatment program for abstinence, which is not I would say, a proximal or short-term goal for many people who have co-occurring disorders. It may be that they can achieve that over 5 or 6 months or even a year, but not immediately. And because of the requirements in the programs, we can see a lack of retention of our patients. Some of the treatment models that I, again, won't go into detail here, but I would encourage you to learn more about integrated dual diagnosis treatment. I have a slide on that very briefly, and some of the other models that are very useful in working with co-occurring disorders. And again, combining these treatment models, these theoretical approaches, these different sets of skills produces better outcomes in our programs. Many of you may not be familiar with the risk-need responsivity model, and this model helps to target independent risk factors for rearrest in our population so that we can reduce the cycling back through the criminal justice system for people that have co-occurring disorders. Integrated co-occurring disorders treatment, this is really one of the last things that I'll mention today, is the most effective approach for treating co-occurring disorders, and it addresses the treatment by providing both interventions for substance use and for mental health disorders simultaneously, provided by the same staff at the same site and with one primary care coordinator who can provide case management, advocacy, and serve it as a navigator between the systems. So again, you can imagine that this probably takes a multidisciplinary staff that are well trained in both sets of disorders and that can manage treatment interventions for both types of disorders. I have these on the slides. I'm not going to go into detail, and because of the time limitations today, we know that integrated treatment oftentimes is a staged process that reflects the level of motivation that a person is at who has a co-occurring disorder at the beginning of treatment, who may not be ready for abstinence-related interventions, but needs to just develop a relationship with treatment staff to begin with, and then moving forward towards other recovery steps. Other adaptations, obviously having staff who are credentialed in both sets of disorders treatment, increasing the length of services. Typically, co-occurring disorder services are about 1/3 longer than traditional addiction treatment services. Slowing down the pace of treatment, we mentioned before, having 45 minutes or an hour treatment sessions versus an hour and a half. And again, focusing on some of these other issues that are very, very important for the co-occurring population. Other things here, again, destigmatizing mental illness and normalizing that that's a really common type of disorder in the general population and that it can be managed successfully. But that it's a lifetime risk that you have and a lifetime need for engagement in services off and on as you need care for both sets of disorders. I'm going to end there and see if we have some questions from our audience. Thank you very much for your attention, for participating today, and like to entertain questions at this point.
Okay, so thank you very much, Dr. Peters, for an excellent presentation. I am monitoring the chat box, but I think it's a testament to your excellent way of explaining things that I did not see a question, but if you do, please take a moment. You can actually unmute yourself or use the chat box for the moment. And yes, yes, Ma'am Diana, hi. Please go ahead.
I think you're muted, Deanna.
There. I'm sorry. Good morning, everyone there. Hi, Roger. Thank you for that great presentation. It was really brilliant, and it was what I needed to listen to, I guess. I had one question, though, because what you presented is just surreal for us, considering our university structure system and how the trainings in the different professions are carried out. I can talk about psychology that I know more of. I'm a psychologist. Our system is that you get, and in all Medical Sur, I mean, this area of South America, the structure of the training is that you get the core courses and the basic courses in your 5-year training, and then as a postgraduate training, you have to get whatever you want to be specialist on. So substance abuse disorder treatment and prevention and rehabilitation will fall under that system. So how can we do you have any ideas that how can we kind of squeeze some contents in the graduate level so that, at least you have the taste, a little taste of what it is like, so that because we have been doing as a Universidad Católica some certificate programs. And we're trying to put together a program for a master's and what we call a specialization, which is another certificate, but it's more profound. But how about the motivation of people? If you don't get anything in the graduate level, you don't even, I don't want to say you don't know, but you are not motivated to go on your studies on an area that you haven't had any other courses in the basic area. So you have any thoughts about that?
Yeah, great points, Deanna. And yeah, I know that you've been developing your academic programs at the university there in Asuncion for many years. So I think you raised some really important points that, first off, if you don't have exposure to co-occurring disorders at the undergraduate or certificate level, you may not be motivated to get additional training or even understand that that's something that you might really want to work with that population, and that you may have some skills already in, for example, navigating different systems of care that could really help in that setting, and that you have some special expertise already. The second thing I think that you pointed to is that, it's difficult in revamping or reorganizing our academic programs that currently exist in mental health or in substance use that are more rare, but particularly in mental health, because there's a set curriculum, right? And oftentimes there's not a specialty course in co-occurring disorders. Here at the University of South Florida in Tampa, Florida in the US, I have taught a co-occurring disorders course in our undergraduate behavioral health care major that is a requirement for our undergraduates in that major. And so I think that's one approach, is to have a freestanding course. But I think maybe even more importantly is to look at your curriculum in let's say the mental health area at the university setting, and ask your faculty, where could you insert content about co-occurring disorders in every single one of your classes? And maybe there are some classes that aren't amenable to that, but even in, let's say, the social context and environment of providing treatment. I think that's a perfect place to have content on co-occurring disorders about the substance use treatment system and how you access that. What are the specific requirements for health insurance and for gaining, having partnerships with that system? And again, recognizing the prevalence rates of co-occurring disorders within that class as a justification for the need to understand more about systems overlap and navigation between systems. So I think that can be an exercise academically for our deans, for our department chairs and heads to look at the curriculum and say, how can we improve that to address this important gap and underserved area for our workforce that are receiving training in our university settings? Does that make sense, Tiana?
Absolutely. Thank you, Ryder. Thank you.
I think the same holds true for graduate programs, that
Right.
there kind of insertion of content about co-occurring disorders in as many of the graduate courses in mental health as we can, and similarly for the newly established addiction studies programs that are emerging all over the world. Thank you.
Thank you.
Thank you, Roger. I like what you said, that the academic managers have the responsibility to actually sort of look into our curriculum, but even as individual instructors, we can actually add content that makes it relevant for all the classes that we thought and that we are teaching. There's a question here about first is technology and innovations. How are we actually integrating all of the new changes that we have into preparation of the workforce, like into teaching? And then the second question is an issue of diversity, equity, and inclusion. And how do we integrate that into our courses?
Right. So the first question was, can you restate that again?
Oh, the first question is, in what ways are technology and innovative approaches integrated into workforce preparation for co-occurring disorders?
Right. Well, I guess one area would be, clearly there are lots of online resources related to this. You know, webinars are streamed. There are a lot of access. If you just Google a co-occurring disorders training, you're going to find tens, maybe hundreds of trainings that are available. So that's one aspect of technology. Certainly, yeah, I think in terms of telehealth, we have options for treating people with co-occurring disorders at remote locations, or also in, I would say, clinical supervision and consulting with staff who might be in a rural area at, let's say, a primary healthcare clinic in a rural part of a country that doesn't have access to specialized treatment staff, right? And so there may be the ability to provide psychiatric consultation to diagnose and prescribe medications for people in an addiction treatment program, for example, or likewise to provide a specialty assessment for people with a co-occurring substance use disorder in that population. So I think opportunities there, lots of different technologies. I think that I would say the technologies related to evidence-based treatments have improved significantly, so that we have evidence-based curricula. A lot of them are in English, unfortunately, and some of those have not been translated. But in that aspect, I think we have a much improved technology for treatment of these disorders than we had even 10 years ago.
Thank you for that. Post-COVID, we are more receptive of technological advancement. And then the next question is about diversity issues. How do we provide culturally competent care to people with co-occurring disorders?
Yeah, and I think the answer to that is it wouldn't be much different than recognizing diversity and cultural issues within a population in mental health or addiction treatment. I think our staff have to be aware of, for example, there are some differences, how stigma is understood and experienced, and how it affects behaviors among people from different ethnic and racial backgrounds, right? I've worked in my international work, there's been certain countries I've worked with where families do not want somebody married into their family who has a family history of addiction or a family history of mental health disorders. And so There are issues like that of stigma there that are really important to understand, and cultural specific beliefs about mental health and substance use. In some cultural settings, in some countries, there's a belief that there's spiritual nature of mental health problems, that there's demons, satanic influences of people that need religious treatment instead of evidence-based practices for co-occurring disorders, and that can be very damaging. But so working with family members to assure them that that their spiritual needs are taken care of, but they're also receiving evidence-based care. So I think there are some aspects that we need to be very aware of, including that address equity, inclusion, diversity, cultural issues.
Thank you so much. And I guess that's going to be our last question. But before we end the session, I would really love to say that I love the fact that you have included screening, assessment, and treatment planning in core competencies, because particularly in some of our settings, I know that some of you came from countries wherein substance use is more anchored in the criminal justice system, like my own country. And normally what happens is that if a person is using substances, they forego the screening and assessment. They just treat it as like a universal or a standard case in which everyone has to go the same treatment. And it's not necessarily a good use of resources. And it's also not for the best of our client. Dr. Roger Peters, thank you very much. That was such an excellent presentation. It was very informative. And as we can see in the chat box, everyone is like commending you for a well presented topic. So with that, we would like to thank you, and we would like to thank the audience. Please be reminded of, we will actually have a lot of upcoming events. You can see this in our ICU DDR newsletter. And if you are not a recipient of that, you can email info@icuddr.org so that we can include you, so that you are aware of what's happening. And remember that ICU DDR webinars and most of our events are actually free of charge. I think all of our events are free of charge. Please disseminate the information not only to your colleagues, but also to your students. We want to prepare the future workforce, so the information that we're sharing shouldn't stay with us. But if you have graduate students, undergrad students, feel free to invite them to our events. With that, so thank you very much and have a good day, good evening for some. For us, it's the beginning of the day. Thank you, Dr.